How's it going, everyone? This is Ahmed Radwan again. We have our exciting new section here, Pediatrics, and this is the first session. In the previous sections, we did 25 minutes per session, and we had a break of 5 minutes in between. I think we're going to try to do things differently here for pediatrics. There is a twist to the Pomodoro technique, and instead of 25 minutes, it's going to be 50 minutes, and 50 plus 10 minutes break. And I think we can do like 10 pages or maybe 9 pages per 50 minutes. I'm hopeful that maybe we'll be able to do that as an average. And we have 63 pages of pediatrics in Master the Boards USMLE Step 3, starting with page 353. So we can do it in like 7 to 8 Pomodoros, or 7 to 8 sessions. Each session is going to be 50 minutes. And I think this would increase our productivity a little bit. I'm going to try to do my best to finish as much as I can in as little time as possible, but at the same time, we need to focus and we need to understand what we're going through, not just read it. And yeah, so with that, please give me your attention and get your book to page 353, and we're going to start pediatrics here. The first thing that we see here is going to be the newborn. Awesome. So, and on newborn here, it says a management of the newborn. So we have a newborn here. I'm assuming he's normal or not. How are we going to approach him or her? At delivery, we do something right away. First, we give 0.5% erythromycin ophthalmic ointment. So this is right away, and we give 1 milligram of vitamin K intramuscular. To prevent hemorrhagic disease. Okay, really easy. We have two basic signs correlate here. I think they are to do with the points we just talked about. And the first one is, it says that erythromycin is a bacteriostatic drug. So bacteriostatic drug, what they do, they inhibit the reproduction of bacteria by blocking the ribosomal formation of proteins. And on the other hand, penicillins are bactericidal, so they kill. Bactericidal antibiotics, they kill bacteria by cell wall inhibition. So this is basic science. The second one, it says that factor 2 and factor 2, factor 7, factor 9 and 10 are vitamin K dependent clotting factors. And it's going to be like 1972. This is just a mnemonic for it. Proteins like S and C, they are vitamin K dependent anticoagulants as well. So vitamin K adds a carboxyl group into the glutamic acid of these factors, and for protein C, this inhibits factor 5. I think if you want to correlate this with the basic science, you need to take a look in general about the coagulation factors and the anticoagulation factors. But in general, it's important to know that vitamin K or vitamin K dependent clotting factors, they have to do with the 1972 factors, and the protein S and C, they are vitamin K dependent anticoagulants, and that's it. If you want to take a look further, you can do so. Okay, so we have the baby, and we give him or her the vitamin K, and we gave the ointment, the 0.5% erythromycin ointment. And now what to do? Before discharge, we administer the Hep B vaccine if the mother has hepatitis B surface antigen, if the mother is hepatitis B surface antigen negative. However, if the mother is hepatitis B surface antigen positive, we give the IVIG for hepatitis along with the hepatitis B vaccine. Okay, so Hep B vaccine along with the IVIG if the mother is positive. And we perform a hearing test to rule out congenital sensorineural hearing loss. We order neonatal screening tests, and these are more reliable if done after 48 hours, not right away. And routine screening tests would include the phenylketonuria, galactosemia, and hypothyroidism. Just a fun fact, in Egypt we only do the hypothyroidism. I don't think we do phenylketonuria and galactosemia, but nonetheless, we should do it in general, and this is in the US. So what we're going to do again, Hep B vaccine, only, mother is negative, mother is positive, give the Hep B vaccine plus the IVIG, do a hearing, perform a hearing test to rule out congenital sensory hearing loss, or the neonatal screening test, which are phenylketonuria, galactosemia, and hypothyroidism. Again, we have something that is called the Apgar Score. The Apgar Score is very famous. It's measured of the need and effectiveness of resuscitation that we do. It's going to be done twice. It's going to be after 1 minute and then after 5 minutes. The Apgar Score here, it does not really predict any outcome, but it is persistently, if it is persistently low, like 0 to 3, this is going to be bad and it's going to be related to high mortality. So we said that there are two scores, one score for the first minute, and then after 5 minutes. The 1 minute score, it gives an idea of what was going on during labor and delivery, and in 5 minutes that gives an idea of response to resuscitation if needed. And I don't think we need to go into details about the 5 points and of Apgar Score and how to score and stuff like that. We just need to know that. And in case we find any questions later on in USMLE World or something like that, we can add that to the book. Okay, so now we have 1, 2, 3 pages, I think. Yes, 3 pages that talk about the abnormalities in a newborn. And I think they are important, and they are in a table format. We're going to go through them. I can't really see all the pictures, unfortunately, but nonetheless, we're going to go through them and in details and try to memorize as much as we can. So the table below here, it lists both benign findings in a newborn and a disorder and what could be the management in just in such cases. So let's get started. First here we have a baby who has blue or gray macules on the pre-sacral bag and posterior thighs, like we see in the pictures here. These are, as a diagnosis, they are called Mongolian spots. They are associated, they're not associated, they usually fade in the first few years, and the further management is to rule out child abuse. So what we should just rule out is the child abuse here. It's not really that big of a problem. The Mongolian spots, and they usually just fade away in the first few years. The second finding here is to have a firm yellow-white papules. Okay, so yellow-white papules and pustules with erythematous base, which peak on the second day of life. This is called erythema toxicum, and it's not associated with anything, and we don't do anything about it. It's self-limited. So firm yellow-white papules with pustules and erythematous and pustules with erythematous base peak on the second day. Erythema toxicum, we don't do anything about it. The third one is a permanent unilateral vascular malformation on the head and neck. This is called the Porto-Wine stain, or nevus flemmis. It's associated with the Sturge-Weber syndrome, which is an AV malformation that results in seizures and mental retardation and glaucoma. A fun fact, I actually saw one case in pediatrics before. And what we should do is we should do a pulsed laser therapy to get rid of the vascular malformation. And if it is Sturge-Weber syndrome, we should evaluate for glaucoma, and we should give anticonvulsives. We usually do a CT so we can see the malformation. On the CT, we can really see it, and we evaluate for glaucoma and give anticonvulsions. Anticonvulsive medication. Okay, so that's the Porto-Wine stain, permanent unilateral vascular malformation on the head and neck. The final one in this page, it's going to be the red, sharply demarcated lesion appearing in the first 2 months of life. They are rapidly expanding and then enveloping by the age of 5 to 9 years. That's going to be hemangioma. Yeah, really easy to spot. It's going to be associated with the more hemangiomas, so we should consider that underlying organ involvement could happen with deep hemangiomas. If it involves the larynx, for example, this can cause obstruction, so we should consider this. And it also may cause high output cardiac failure if it is really large. Okay, All right. What we should do in a further management, we can treat it with the steroids or pulsed laser if it is large, and or if it interferes with the organ functions. So again, red, sharply demarcated, raised lesions in the first 2 months of life and expanding and so on, and then involute by the age of 5 to 9 years, hemangioma. Okay, so we talked about the blue-gray macules, which are the Mongolian spots. We talked about the firm yellow-white papules, which are the erythema toxicum. The permanent unilateral vascular malformation is going to be Port Weinstein, and the red sharply demarcated lesions is going to be hemangiomas. So that's the first table, or the first page. Now the second page, it says here that we might see something called the Pitty auricular tags or pits. Just like the picture here, we have tags or pits, Pitty auricular area. And the diagnosis is the same thing, periauricular tags and pits, and associated with two things here, the hearing loss and genitourinary abnormality. And for the hearing loss, we should do a hearing test, and the genitourinary abnormalities, we should do a kidney ultrasound. Really easy. The next one is going to be defect in the iris. I can't really see the picture well, but I imagine how it looks. And the diagnosis here is going to be coloboma of the iris. And it's associated with the other eye abnormalities, and there's something called the Discharge syndrome that could have coloboma, and we should consider the other things in that syndrome. It's going to be heart defects, atresia of the nasal choana, growth retardation, genitourinary abnormality, and ear abnormalities. And of course, what we should do is to screen for the Charge syndrome here. And again, Charge, C is for coloboma, H for heart, and heart defects, A is for atresia of the nasal choana, and R is retardation or growth retardation here. G, genitourinary abnormalities, and E is for ear abnormalities here. Okay. The next one is going to be absence of the iris, and it's going to be called iridia. This is associated with Wilms tumor, and what we should do is to screen for Wilms tumor with an abdominal ultrasound, Q3 months until the age of 8. Okay, every 3 months until the age of 8. Wilms tumor associated with iridia, or the absence of the iris. The last one is going to be mass lateral to the midline. Usually this is called the branchial cleft cyst. As a remnant of the embryonic development. What we can have associated is the remnant of the embryonic development associated with infections here in that case. So we can see we can have some infection. So what we do is that if we have an infected cyst, we give an antibiotic, and later we can do surgical removal if it is large. And remember, this is lateral to the midline. That's different from the midline ones, where we can, which will we approach in just a little bit. So again, in that we have 4 defects or 4 findings that we can see. The periauricular tags, which would be associated with hearing loss and kidney problems. The defect in the iris, which would be in the Charge, called coloboma. In the Charge, remember the Charge syndrome. Absence of the iris, remember it is called the iridia, and has to do with Wilms tumor, a mass lateral to the midline, that's a branchial cleft cyst, and what we should do is consider if there is an infection, or large, which will affect the breathing and so on, then we should surgically remove it. We have two rectangles here with basic science correlates. We're going to approach those right away, but first I would like to finish the table first. So let's just shift to the next page, and then we'll come back to those. In the next page, we have here multiple other diseases or findings that we can see, and the first one is going to be mass in the midline that moved with swallowing. Of course, any mass moved with swallowing, this going to be has to do with the thyroid, and of course this is the thyroglossal duct cyst, and this is going to be associated with infections and may have a thyroid ectopia. So we should consider those two. What we should do is we do a surgical removal right away, and we do a thyroid scan and thyroid function test preoperatively to make sure that there are no thyroid ectopia or something like that. Okay? All right. So the second one is going to be GI tract protrusion through the umbilicus with a sac. This is called the Umbilicus. We talked about that early before. And this is going to be a failure of the GI sac to retract at 10 to 12 weeks gestation. This is associated with malformations and some chromosomal disorders. We screen for trisomy 13, 18, and trisomy 21. So Edward, Patau, and Down syndromes. So we screen for those. And the basic signs correlate. I think they had to do with these two in the first two findings. And what we see here, it says that a thyroglossal duct cyst. This is going to be maybe formed anywhere along the thyroglossal tract, so it doesn't have to be at the site of the thyroid, which is formed from the descent of the primordial thyroid gland at the base of the tongue. The duct usually atrophies, but a cyst may form, just like we have here. The second correlate, it has to do with the GI tract protrusion or the Umbilicus. It says that in embryology, the intestines are formed outside the abdomen, and then they extend into the umbilical cord until 10 weeks. At that time, they migrate into the abdomen. So if they don't, we will have an Umbilicus here. Before I go further, I'd actually like to go back to surgery, the pediatric surgery, and see the difference between gastroschisis and Umbilicus. So just a moment here, and we have here pediatric surgery. I'm going to say the page, but just a second. Just a second, we have pediatric here. All right, here we go. On page 334, it says here gastroschisis and Umbilicus. As a reminder here, the gastroschisis is going to be the umbilical cord is going to be normal, so this reaches the baby, and the defect is to the right of the cord, where there is no protective membrane, and the bowel looks angry and mated. Umbilicus, we see here, this is going to be different because it has a sac. The umbilical cord goes to the defect itself, and which has a thin membrane under which one can see the normal looking bowel, and a little slice of the liver as well could be seen. So this is the difference between the Umbilicus and the gastroschisis. As a reminder also for the basic signs that the incomplete fusion during the 4th week of development would result in a defect that allows the abdomen viscera to protrude through the anterior body wall, which is made when the lateral body folds move ventrally and fuse into the midline. So this is when we might see a problem in general. But in gastroschisis, this occurs when the neural crest cells fails to migrate, and this is going to be resulting in the absence of the enteric neurons within the mesenteric plexus and the submucosal plexus. So again, we have gastroschisis and the Umbilicus, the difference, the sac, and whether or not the umbilical cord is going to be normal or it's going to be directed towards the defect here. And that's been it. Okay, so let's get back. We are on page now with 357 in the table, and we are talking about abdominal defect lateral to the midline without a sac. And that's going to be the gastroschisis here. And the abdominal defect lateral to the midline without a sac, again, the gastroschisis. It's associated with intestinal atresia. And what we should do is we do a surgical correction. And it says here C section 4 surgery. And what we did, we just did that. So again, gastroschisis and Umbilicus, and we should know the difference. Okay, the next one, it's going to be congenital weakness, where vessels of the fetal and infant umbilical cord exited through the rectus abdominis muscle. Well, generally this is the umbilical hernia, and it's associated with congenital hypothyroidism. Okay, so we should screen with TSH right away, of course, and we screen anyways. And the further management is that it may close spontaneously. I think we should wait. I can't really remember exactly how many years. I think 2 years maybe. And for the umbilical hernia, and if it closes, that's fine. If it doesn't, then we should do surgery. The next one is going to be called the scrotal swelling, and it's transillumination along with it. This is called the Hydrocele, of course, and could be associated with the inguinal hernia. And this should be differentiated from the inguinal hernias in any way. And the next one is going to be unilateral absence of the testes in the scrolla. This is undescended testis, and it's associated with malignancy if more than 1 year of age, testicular malignancy. And what we should do is that no treatment until 1 year of age, and then hormone injections, beta HCG or testosterone, and we do orchopexy as a surgery for treatment. And this is going to be until 1 year of age. So again, let's get back here to that part, the scrotal part. It's going to be either scrotal swelling and translamination, hydrocele associated with the inguinal hernias, and if it's unilateral absence of the testes in the scrotal, that's undescended testis associated with malignancy, and we should take care of that. And for 1 year, we don't do anything. And after that, we can do hormonal injections or testosterone or beta HCG, and we should do surgery, which is orchopexy. Okay. Again, we have here the urological problems here. It's going to be like urethral opening on ventral surface, and that's going to be called hypospadias, and it's associated with other gastrourinary abnormalities, which could be present most commonly. It's going to be undescended testes and inguinal hernias. And what we should do is that we should not circumcise that patient. If we have the urethral opening on the dorsal surface, however, that's going to be epispadias, and it's associated with the urinary incontinence. And what we should do is that we should do surgical evaluation for bladder exstrophy. Finally, if we have an inguinal bulge or reducible scrotal swelling, that's going to be inguinal hernia. Usually it's indirect. And what we should do is we should do surgery. Again, now, so let's just review right away what we had here. We had here the genitourinary ones. It's going to be scrotal swelling with the transillumination, hydrocele, unilateral absence of testis, that's going to be undescended testes, urethral opening in the ventral sulcus, hypospadias, epispadias, that's going to be the urethral opening on the dorsal surface, inguinal bulge or reducible scrotal swelling, that's going to be inguinal hernia, usually indirect. So that's been the abnormalities in the newborn, 3 pages here. And we did really well. I would suggest that after we're done, we can review those again and try to memorize as much as we can to help us with it. Okay, so we're done with this part, and let's go to the next page, and we have a question. The next page says here that you are called to see a 9.5-pound newborn boy who is jittery 30 minutes after a bath. The pregnancy was complicated by prolonged delivery with shoulder dystrophy or dystocia. Physical exam reveals a large plethoric infant who is tremulous. A pan-systolic murmur is heard. Which of the following is the most appropriate diagnostic test? So A here, it says bilirubin level. B, that's going to be blood glucose. C, galactose level. D, serum calcium level, and E, it's going to be serum TSH. Of course, it's blood glucose level. That's going to be infant to diabetic mother, and he's large and he's going to be large for the gestational age when followed in pregnancy, and he is having some signs of hypoglycemia, I think. So what we should do is a blood glucose level. So the answer is B, of course. That's blood glucose level is the best initial test to evaluate the infant that presents for large for gestational age, plethora and jitteriness. This child most likely born to an infant of a diabetic mother, of course. It says here that we should look for macrosomia, all organs except the brain are going to be enlarged. History of birth, trauma, and cardiac abnormalities like cardiomegaly. The case may not give a history of diabetes in the mother, so we should consider that just in case. And what we do is that we treat with glucose and small frequent meals. Okay? All right. Awesome. So let's get into the infant of a diabetic mother here in some details a little bit. In terms of the lab abnormalities, we're going to see the infant is going to have some hypoglycemia. This is going to be after birth. He's going to have also hypocalcemia, hypomagnesemia. So that's 3 hypos. Glycemia, calcemia, magnesemia is going to be low. And he's going to have 1 high, or 2 highs, the hyperbilirubinemia and polycythemia. So again, hypoglycemia, hypocalcemia, hypomagnesemia, hyperbilirubinemia, and polycythemia right after. Okay, so an infant of diabetic mother is associated with two things. It's going to be cardiac abnormalities like atrial septal defect, ventricular septal defect, and truncus arteriosus. That's why in the question we had a pan-systolic murmur. And the second thing is going to be small left colon syndrome, and it's going to show as an abdominal distension. So it's going to be cardiac and colon problems. Again, in this case, the infant of diabetic mother is going to be also associated with an increased risk of developing diabetes and childhood obesity. Those two things, it could happen as well. So the infants here, they become hypoglycemic after delivery, and that's a why. And why do we ask this? This is because of the excess insulin in the utero. They accumulate to a high glucose environment. They acclimate to a high glucose environment, and by producing more insulin, becoming hyperinsulinemic. At birth, upon leaving this high glucose environment, he's going to have really high insulin, and he's not really having any glucose after he's been born, so he's going to be hypoglycemic right away. And we should take care of that. Okay, and we're done with the infant of diabetic mother, and let's talk about the respiratory distress in newborns here. In respiratory distress in newborns, we keep the following in mind for any case of respiratory distress in newborn. The first is that the best initial diagnostic test is chest x-ray. Okay, so what we should do is to order chest x-ray in any case that we suspect respiratory distress in newborn. What other diagnostic studies that we should do is ABG, of course, blood cultures, if we think about sepsis, blood glucose, and if he's hypoglycemic, CBC if anemia or polycythemia, and cranial ultrasound in case of intracranial hemorrhage. The best initial treatment, however, is going to be oxygen. We should keep the oxygen saturation of above 95, and we should give nasal CPAP if the high O2 requirements to prevent barotrauma. And if there is high O2 requirements to prevent the barotrauma and the bronchopulmonary dysplasia. And finally, we should consider the empiric antibiotics for suspected sepsis. So 3 things to start with the treatment here is going to be the oxygen to keep the saturation above 95%. We give nasal CPAP if the high O2 requirements to prevent barotrauma and bronchopulmonary dysplasia if we need that. And finally, we should consider the antibiotics to suspected sepsis if there is any. It says here as a tip here, in case of newborn respiratory distress, when hypoxia does not improve with oxygen therapy, we should evaluate the patient for cardiac causes of hypoxia. So first, we should consider a chest X-ray and so on, like we said before, that would indicate there is a problem with the chest. If not, we should consider the cardiac causes of hypoxia, something like the congenital heart defects, of course. Okay, so now start with the individual problems here, like respiratory distress syndrome first. What we're going to see is that clinical features is going to be a premature neonate, and it's going to have tachypnea, it's going to have nasal grunting, intercostal retractions within hours of birth. So this is basically just respiratory distress. And the hallmark finding is going to be hypoxemia, of course. Eventually, hypercapnia and respiratory acidosis develop. So we said the hallmark is going to be hypoxemia, and hypercapnia and respiratory acidosis develop later on, and respiratory distress syndrome. How are we going to diagnose this? The diagnostic test is a best initial test, and that's going to be the chest X-ray. We're going to see ground glass appearance, that's the buzzword, and we can see atelectasis and air bronchograms. That's going to indicate the respiratory distress syndrome. And the best predictive test is going to be the LS ratio on amniotic fluid prior to birth, the lecithin sphingomyelin ratio on the amniotic fluid. This is the best predictive test. How are we going to treat that patient? The best initial treatment is going to be oxygen and nasal CPAP. And the most effective treatment is exogenous surfactant administration, and this is proven to decrease the mortality. So the best initial is going to be oxygen. The best effective is going to be exogenous surfactant administration. We have two side notes here. That says the first one says that pneumonia and respiratory distress syndrome, they look identical in chest X-ray. So when in doubt, we just give antibiotics. We do that. And lisinactant, the second here note, it says lisinactant is the first synthetic peptide containing surfactant approved for treatment of the neonatal RDS. Okay. We have a note here for basic science correlate. It says that the mechanism of surfactant here. It says that surfactant, it prevents the collapse of the alveoli by decreasing the surface tension. And also surfactant is going to be produced by type 2 pneumocytes, which start to develop around 24 weeks gestation. However, not enough surfactant is secreted unless, until the 35 weeks gestation. Okay. So what should we do for primary prevention? How do we prevent such a problem? The first is going to be antenatal beta-methazone or steroid. This is most effective if it's going to be more than 24 hours before delivery and less than 34 weeks gestation. The second is going to be to avoid prematurity, so we give tocolytics to stop the mother from going into labor, and we give corticosteroids immediately to any fetus in danger of preterm delivery of less than 34 weeks. And finally, postnatal corticosteroids do not help and are not indicated. So antenatal beta-methazone, this is effective in more than 24 hours before delivery and less than 34 weeks of gestation. Avoid prematurity by giving tocolytics and steroids immediately to any fetus in danger of preterm delivery less than 34 weeks. What are the possible complications that we can see? The first is going to be due to hypoxemia. We can have retinopathy or prematurity. We also can have a bronchopulmonary dysplasia, and this is prolonged high concentration of oxygen. We can prevent that with CPAP, and intraventricular hemorrhage could occur as well. So those are the complications. As a reminder for the treatment, we should give oxygen and nasal CPAP, and the most effective treatment is going to be the exogenous surfactant administration. Okay. The second thing, second disease here, or respiratory distress disease, is going to be the transient tachypnea of the newborn. Transient tachypnea of the newborn, this presents as tachypnea after a term birth. So that's not going to be a premature one, of infant delivery by cesarean section or rapid second stage of labor. This is likely related to retained lung fluids. The condition usually resolves 24 to 48 hours. We have a basic science correlate here that says that the transient tachypnea of the newborn, this is caused by retained lung fluids, again, and that is fluid present in the lungs in utero, does not get squeezed out in passage through the birth canal. The two risk factors is going to be the rapid stage 2 labor and the CS. An increased fluid in the lungs causes increased airway resistance and decreased lung compliance, of course. How are we going to diagnose it? Of course, we said the first thing to do is the chest X-ray, and we're going to see air trapping and fluid in fissures and perihilar streaking. How are we going to treat it? The best initial treatment is going to be, again, oxygen. So we should follow that with most of the problems that we're having here. And minimum requirements is going to be for the oxygen in this case, which results in rapid improvement within hours to days. So really easy. Okay, the third is the meconium aspiration. This presents as severe respiratory distress and hypoxemia in a term neonate with hypoxia or fetal distress in utero. The meconium past may be aspirated in utero or with the first postnasal breath. So as a basic science correlate, the meconium is the first stool a baby passes. It is sticky and it's like tar and is composed of epithelial cells, lunule, mucus, bile, and amniotic fluid. Fetuses in distress often pass meconium before birth. So meconium aspiration, the causes could be the meconium aspiration would cause a blockage of the alveoli. It can have decreased gas exchange and irritation of the airway, which would cause inflammation and then later on pneumonia. Serious disease here. We're going to diagnose, of course, by doing X-ray. We're going to see patchy infiltrations. We're going to have increased the AP diameter or a barrel chest, and we're going to have flattening of the diaphragm. So three things here: patchy infiltration, increase the AP diameter, and flattening of the diaphragm. As a reminder here, the transit kidney of the newborn, we're going to see air trapping, fluid in fissures, and perihilar streaking. And for the chest X-ray and the respiratory distress syndrome, it's going to be the atelectasis, the ground glass appearance, and air bronchograms. Okay, how are we going to treat meconium aspiration here? The first is going to be positive pressure ventilation, high frequency ventilation, nitric oxide therapy, and extracorporeal membrane oxygenation. What do we do to prevent? We prevent by performing an endotracheal intubation and airway suction of depressed infants, so we can suck that meconium out. The possible complications, of course, is pulmonary artery hypertension, air leak, so maybe pneumothorax or pneumomediastinum, and finally it's going to be aspiration pneumonitis. Okay, so we're done with the meconium aspiration here, and we're doing really well. It's been 36 minutes so far, and we are going really well on schedule and going strong. So let's continue. The diaphragmatic hernia, that's the next thing here. Diaphragmatic hernia, this is going to be presented as respiratory distress and scaphoid abdomen. And we're going to diagnose it, of course, with a chest X-ray, and we'll look for loops of bowel visible in the chest or the liver on the other side if it is on the right side. The treatment, of course, immediate intubation, and this may require extracorporeal membrane oxygenation, and it's going to be followed by surgical correction. So we're done with the respiratory distress diseases that we might see. And we are going to the gastrointestinal and the hepatobiliary disorders here. Okay, so the first thing in the GI and hepatobiliary is going to be the meconium plugs, or in the lower colon, or meconium ileus in the lower ileum. This is going to be is going to present initially with an intestinal obstruction. Associated conditions might be small left colon in infant or diabetic mother, Hirschsprung disease, cystic fibrosis, and maternal drug abuse. That's going to be in case of plugs or in case of the colon problems. And in ileus, that's going to be cystic fibrosis. So if a patient has cystic fibrosis, or if he has ileus, we should suspect cystic fibrosis. If he has plugs, we could suspect that the mother has been diabetic due to the small left colon. He could have Hirschsprung disease, cystic fibrosis again, and maternal drug abuse. How we're going to diagnose it? The best initial test is going to be an abdominal X-ray to see the intestinal obstruction, and to treat it, we treat the ileus with gastrografine enema. Okay, so we have a question here in upper gastrointestinal malformation. Let's start with a question. It says here, a newborn is born by normal vaginal delivery without complications. There is no respiratory distress. Upon his first feed, he is noted to have prominent drooling. He gags and develops respiratory distress. Chest X-ray reveals an infiltrate in the lung. Which of the following will confirm the diagnosis? Arterial blood gas, blood culture, CT scan of the chest, nasogastric tube placement, and gastrography. I think it's going to be D. Yeah, of course, since nasogastric tube placement. This confirms what we studied in the surgery, the pediatric surgery. And what we have here is going to be a tracheoesophageal fistula. This patient has that, the TEF, and classically there is choking and gagging with the first feed and respiratory distress later on due to the aspiration pneumonia. The feeding tube will be coiled in the chest, and we do not forget in this patient to look for other abnormalities associated with Bactero. Again, This is the mnemonic. V is for the vertebral defect, A for anal atresia, C is for the cardiac abnormalities, T is for the tracheoesophageal, T is for the tracheoesophageal fistula and esophageal atresia, and R is for radial and renal abnormalities, and L is for the limb syndrome. So that's been this part. And basic science correlate here says that TEF, or tracheoesophageal fistula, is an embryological malformation, division of the cranial part of the foregut into the respiratory and esophageal parts is incomplete. So we don't have complete division. This occurs at week 4 of development. So week 4, remember that. It says here also that a premature infant is born by normal vaginal delivery without any complications. There is no respiratory distress. Upon the first feed, she begins vomiting gastric and bilious material. The chest x-ray here is showing. What is the most likely diagnosis? I can't really see the chest x-ray, so I can't really see what the diagnosis is. So I'm going to just take a look at the answer. The answer says here that the most likely diagnosis is duodenal atresia. Okay, so half of infants with this condition are born prematurely. So here we have a premature infant. And the second, and the condition is going to be associated with Down syndrome. We don't have that in the question, but just in case, we should know that. We look for polyhydramnios in the prenatal exam. And as a condition that is associated with Down syndrome, of course, and because the patient is not able to swallow, while being a fetus or the in utero, so we're gonna have polyhydramnios because of that. The treatment was gonna be involving a nasogastric decompression and surgical correction. You must search for other abnormalities, Rectal, again, with an x-ray of the spine, abdominal ultrasound, and echocardiogram. I think in the chest x-ray, I can't really see it, but I think it's the double bubble sign, which would mean either duodenal atresia or an annular pancreas, I think, yeah, maybe. Yeah. I can't really see it well, but anyways, we have a side note here that says the DDX of a double bubble. Oh, okay, so that's what we're saying here. DDX of the double bubble seen on a chest X-ray, on an abdominal X-ray, would include the duodenal atresia, annular pancreas. All right, so very good, and malrotation and volvulus. Okay, awesome. A basic science correlate here. It says that during duodenal development, the lumen is completely occluded by the epithelium, then is reformed. The failure of reforming of the lumen would cause the duodenal atresia. Okay, we're done with the duodenal atresia, and we are now approaching necrotizing enterocolitis. Okay, so necrotizing enterocolitis here. It presents in premature infants with low Apgar score and bloody stools, apnea, and lethargy when feeding is started. So, again, low Apgar scores, bloody stool, apnea, and lethargy when feeding is started. The abdominal wall is going to show erythema and distension, which are signs of ischemia here. And the necrotizing enterocolitis is a true medical and surgical emergency here, with 50% mortality related to ischemia, inflammation of the bowel, and ultimately perforation. The greatest risk factor is going to be premature delivery. So anybody who has premature delivery, we might think of necrotizing enterocolitis, especially if it has Apgar score, and when we start feeding, we see a bloody stool, apnea. I'm sorry, and lethargy. So how are we going to diagnose that patient? The best initial diagnostic test is going to be abdominal X-ray, and an ultrasound may also be helpful, but the best initial test is going to be abdominal X-ray. We have an X-ray here. It says Pneumatosis intestinalis is associated with necrotizing enterocolitis. I don't know what that is actually. I'm really sorry. But a side note here says that pneumatosis intestinalis is the pathognomonic sign of necrotizing enterocolitis on radiograph, seen as gas cysts in the bowel wall instead of the bowel lumen, which is normal. Okay. So cysts in the bowel wall, pneumatosis intestinalis. Okay. A side note also says that there is an increased risk of necrotizing enterocolitis with formula feeding. Okay. So formula feeding would have that premature infant who has formula feeding, necrotizing enterocolitis. Okay. So how we're going to treat it? The best initial therapy is going to be to stop all feeding, decompress the gut, begin broad spectrum antibiotics, and evaluate for surgical resection. Okay, very good. Okay, so we are at page 364, and we have approached the 45 minutes. We still have 5 minutes, so we can actually get done with just last disease, which is failure to pass meconium, and then we're gonna conclude this session and have 10 minutes break. So finally, the failure to pass meconium here. The best initial test to see how to do is a rectal examination. A patient's rectum with passage of a large voluminous stool after digital exam would suggest the Hirschsprung disease. And the next step to do a barium enema, a megacolon proximal to the obstruction could show. The best confirmatory test is going to be the rectal biopsy. And it's going to show absence of the ganglionic cells, would confirm the Hirschsprung disease. And to treat, we're going to do a surgical resection of that part that has the absence of ganglionic cells. And absent in an opening on exam as well would suggest the imperforated anus, and the treatment is, of course, surgical reconstruction. Okay, so we're done with the failure to pass meconium and the X for it. And we're going to take a 10 minutes break. And later on, we're going to start jaundice in newborn, and hopefully we'll do well in that part. Okay, so that's been it. Have an awesome break, and I'll see you in the next one. All right, bye-bye.